Welcome to podcast 12.
I'm Fran.
And I'm Minnie.
And as always, we'd really appreciate your feedback on the forum. Thank you. So today's topic is taking a dermatology history and how to do a dermatological examination. These have been requested by one of our volunteers, who is a professor of dermatology, known as Doc Wright on our system. And the reason he wants us to do this is because if you out in Zambia can better describe the skin condition when you're putting through a case to the virtual doctors, it really helps them with the diagnosis and to respond more accurately.
And our tip, Fran, leading on from that for this podcast, is that when taking photographs of a skin lesion, aim to take at least one close up for the detail of the lesion and one at a distance to give a bit of perspective, and also to check that the photos are in focus before you attach them to the history.
Brilliant. Thank you very much. And in fact, so I have a similar system with my local dermatologist up at the hospital, and I actually send a lot of photos up, and I agree that so I normally take quite a few to make sure they're in focus, particularly when you're doing close-ups, because it's very easy with a phone camera for them not to be in focus. And actually I found writing this podcast very helpful because it was a really good reminder for me to be doing all of these things. So I hope it helps you guys as well.
Great. So let's start with the key questions that we take when we're doing a dermatology history. So when someone comes to you with a rash, for example.
Right, so it's very similar to a normal history. So we're going to talk about the presenting complaint, so ask them why they've come and find out about the nature, the site and the duration. So how long has the problem been going on for? Right,
and particularly about the skin, you want to know when they first noticed the lesion or the rash and how it's evolved from there.
Yeah, so. And symptoms that you're asking about with skin would be things like itch and pain, bleeding and blistering. So those are particular things you might ask for.
And I guess another really important thing, Fran, is to ask whether they've used any particular treatments on it and whether any of these have been effective or not, or if they've used any herbal remedies or anything, anything that you might not have heard of, for example.
Absolutely. And also other things that might be relieving factors or aggravating factors, in fact. So, for example, with eczema, some clothes would aggravate the skin just by rubbing on it. And then we're going to go on and ask about recent contact. So if you're thinking it could be an infectious thing, something like chickenpox, you'd want to know about that. Stressful events. Unfortunately, skin reacts to stress, as to most medical conditions. So chronic skin conditions like eczema can get worse when people are stressed. Recent illness, so there are some rashes that viral rashes in kids we see a lot. I see a lot of in the UK. So you'd want to know about recent illnesses and also travel. Maybe they've been somewhere different, been exposed to different chemicals or mosquito bites, something like that. Yeah.
Okay, and also history of sunburn, I guess, is another thing that we would want to know about.
Particularly at the moment in the UK, because it's suddenly sunny and everyone is coming in with a very burnt skin.
Shirts off.
Shirts off, right. And then, so it's just a typical history. So then you'd go into the past medical history. So you'd want to know if they've got any history of atopy, which we've discussed in other topics. So asthma, allergic rhinitis, eczema, and any history of skin cancer or suspicious lesions. And any family history of skin diseases. So we know that there are certain rashes that run in families. For example, psoriasis has a very strong hereditary link.
And moving on from family history, their social history is really important too. So what they do for a living, their occupation, because that may have a lot to do with what they're coming into contact with their skin. So if you're cleaning, hairdressers,
even GPs. So last year, one of my patients very kindly passed their strep throat to me. And one of the unusual complications of having a strep throat is you can get a type of psoriasis called guttate psoriasis. So I then got guttate psoriasis. So even being a GP is a risk for getting strange skin rashes from work.
Okay, thank you for sharing that with us, Fran. And the other thing is to find out if these lesions improve when you're away from your place of work. Because that could also
and that's very much with
the
contact things, isn't it? Like in cleaners and stuff. And then we talked about medicines they might have tried. So you'd want to know if they're on any other medicines, because again, for example, with this guttate psoriasis rash, which I had, things like beta blockers can be linked to triggering that off, and also any allergies. There are some creams that we use that, for example, have peanut oil and stuff, so you want to be careful of allergies.
Okay. I'm just thinking of quite a few of the cases that we've had on the forum, on the website. The treatment for the HIV treatment, quite a few of them can cause rashes, can't they?
Yeah, a lot of them can. So it's really important to include the medicines. Thanks, Winnie. Yeah.
Okay, so why is skin important?
It has a massive impact on quality of life, doesn't it? And this is something that probably we should be asking patients. So certainly, if they're itching from eczema or other rashes, it might be affecting their sleep. And we know that has, particularly with kids with eczema, that has a huge impact on how school, their growth, behaviour, things like that. Can make people incredibly self-conscious. And in fact, that was really interesting for me when I had the guttate psoriasis. So although it wasn't terribly bothersome, as it spread, I got more and more self-conscious about it. So patients would come in and say, "Oh, I have a rash," and then they'd be like, "Oh my God, not like yours."
No.
At that point, I thought I might just go and get some treatment for this, because it does make you self-conscious, and we know. It can really be linked with depression. That people with acne, they feel very
self-aware,
very low. Yeah, it has a massive impact on their mood. So ask people, is this having an impact on their life? Because I think that's really important.
Yeah, absolutely. So once we've asked the history, we need to go on to examine the skin, and there are 4 important principles in performing a good examination of the skin. And they are to inspect, to describe the lesion, palpate, and then do a systematic check, which includes the nails and hair.
Brilliant. So inspecting, so that's just looking. It's a posh way of saying look. So you're going to look at the person. Yeah, so you're going to do a general observation. You're going to look at where the skin lesions are and the number of them. And if there are lots of them, you're going to look to see if there's any sort of pattern of distribution or how they're configured.
And I think, sorry to interrupt you, Fran, but I think important as well to look at areas of the skin that an individual might not actually be able to see themselves. For example, the back or the back of the legs and the back of the neck.
Yeah, I think that's really true. Yeah. So
you may not realise that you have rash elsewhere.
Yes, and I certainly, when I had my rash, I was forever going into my husband and saying, "Does it look worse?" and turning around so he could see my back. So once we've inspected, so we're getting an idea, so are they localized? For example, a mole or a patch of ringworm. Is it widespread, so all over the body, like chickenpox? And then if it is widespread, is it symmetrical? So that means, is it equal on both sides? And if so, is it central? So is it mainly on the trunk? So there's a rash called pityriasis rosea, which is classically described as a Christmas tree rash that you get on your trunk only. Although, to be honest, it never looks like a Christmas tree to me.
It's your imagination.
I think that's a lot of imagination going on. Or is it symmetrical and peripheral? So HSP is a rash that people get on their legs and up to their buttocks. Is that right?
Purpura, yes. So buttocks and the back of down the legs. That's right.
Yeah, and so that's generally symmetrical, but it's in the periphery. So that's arms. So sorry, not arms in this case. It's just in the legs.
Well, you do get it. You can get it in the arms and on the body as well, actually. But yes, classically, it's legs and buttocks.
Yeah. Okay. Does it involve the flexures or the extensor aspects of the limbs? So flexors, so that's on the inside, and that's typical with eczema, and whether it's extensor is more psoriasis based. Is it limited to where the sun is touching the skin? So, I mean, sunburn's absolutely classic in the UK, but in Zambia, something like pellagra typically causes a rash.
And we've certainly seen a couple of cases of that through Virtual Doctors, haven't we?
Yeah, we have. Yeah, sadly. Is it linear? So is it in a line? So, for example, psoriasis, if you scar, you can get something called a Kobner phenomenon where your psoriasis develops in a scar, so that would be in a nice line. Is it in the pressure areas? Are these pressure sores like in your buttocks or your heels? Is it in a particular region? So is it just in the groin and the axilla? And there's a horrible skin disorder called hidradenitis suppurative that just affects the glands that are in the groin and the axilla. So is it just in those areas? And then finally, does it follow what we call a dermatomal pattern? So that's the pattern that a particular nerve supply to the skin follows, and that's that's classic for shingles.
Yeah, that's it.
Yeah. So that's our
inspection.
Right, what are we doing next?
Then we're going to describe what we're seeing, and there's quite a lot of dermatological terminology, which is quite useful, so that if everyone uses it, we all know what we're all on the same page. We understand what we're talking about.
Yep.
So this has another acronym, of course, and this is SCAM.
Yep.
So I'll start with S. So S is for size and shape. So you're going to describe the size and shape of the lesion that you're seeing. So is it discrete? So that's little individual lesion, well, not necessarily little, but individual lesions that's separate from each other, or are they merging together? And this would be a confluent shape. Are they in a line, which we would say linear? Concentric rings, so a target lesion, for example, erythema multiforme, or annular, which is like a circle with a clear centre, which you would see in ringworm.
Yeah, we see that lots, don't we? Yeah.
And discoid is another word to use, which would be a coin-shaped or a round lesion, which discoid. Eczema would be one. Was your guttate psoriasis, would you say that would be described as discoid? Or
no, I think it was mostly discrete lesions. So it was tiny little ones just all over me. Yeah.
Okay. Sorry to use you as an example, but
no, I don't mind it. No, it was quite interesting, and I think the really interesting thing about being a GP is that if you or family members have an illness, it gives you a little bit of insight into what it's like being a patient, and I think that's no bad thing. And I think probably I'm nicer to patients when I see them with rashes, because I have a bit more of an understanding of how it feels. Yeah. And interestingly, that summer I diagnosed another few people with guttate psoriasis as well, which was quite fun. So I felt like an expert very briefly.
Yeah, excellent.
Right. So going on from so we're using the SCAM acronym still. So we've done the S. So the C is for colour. So we're going to describe the colour. So a redness which blanches, so that means pales when you press on it. That is called erythema. If it doesn't pale when you press on it, then it's called purpura. And the purpura is due to bleeding into the skin or the mucous membranes. And if they are small purpura, then they are called petechiae, and they are tiny little pinpoint ones. And if they are large bruise-like patches, they are called ecchymoses. And the classic things which give you purpura are HSP, which we talked about earlier, and meningococcal septicemia. And in fact, sorry, Minnie.
I was just going to say, and petechia is something that you often see after someone's been vomiting around their eyes from sort of increased
pressure.
Yeah.
Yeah, and so in the UK, one of the ways that they've done a public health message on meningococcal septicemia, and one of the things that they suggest people do is to roll a glass over a rash to see if the rash goes or not. So if it goes when you roll over it, then that is erythema, because the skin goes back to normal. And if the rash doesn't go, then that is a purpuric rash. Then we've got patches of paler skin are called hypopigmentation. A classic one, which in fact we've seen on the website, is pityriasis versicolor, which is a fungal infection, or you can also get it post eczema with some inflammation. And that's different to depigmentation, when you actually have white skin, and that is due to an absence of the melanin, which gives the skin the colour. And that's most commonly seen in vitiligo, or occasionally in leprosy, although leprosy is much, much rarer, luckily, than it used to be. And then finally, the opposite, which is hyperpigmentation, and that's patches of darker skin, much more obvious on white skin, obviously. And the classic is something called melasma, which women typically get. So they get this darkening on their cheeks and on their abdomen when they're pregnant, and that's due to the sort of hormonal changes.
Great. So that covers colour. And we'll move on to A, which stands for associated secondary change, which is just sort of a result of sometimes what you do, or a result of the cause of the rash.
Yep, brilliant.
I haven't explained that very well, sorry. So we'll start.
I think it makes sense when you talk about it.
Yeah, probably. So excoriation, this is the loss of the epidermis following trauma. So when you itch, for example, if you have eczema and you itch, then you can excoriate and cause some bleeding.
It's a posh way of saying scratch, isn't it? It's when they've scratched the skin.
Thank you.
Yes.
So if you keep scratching, you can make the skin lichenified. So this causes an area of roughened skin and accentuates the skin markings.
And that you see a lot, don't you? Yeah, so that you see a lot in long-term eczema. So it's not something. Someone has a new rash, they're not going to have lichenification. It's when somebody has been scratching their skin for months and months that you get this sort of thickening of the skin. It's very obvious. And in fact, sorry, I didn't say at the start, I'm going to attach something from the British Association of Dermatologists to this podcast, and it has some lovely photos for each of these things that we're talking about with the SCAM acronym. So it's got photos for each of these, which please have a look at, because it may make a bit more sense.
Make much more sense, probably. Yes.
Yeah.
So next thing is scale. So these are sort of flakes of skin that you'll see, that you often get with psoriasis. So a sort of silvery hue. A crust. So if you've been scratching and you've got a dried area of blood and serum, and a bit of exudate, this is called it's dried over. You get a crust. So you'll see this in impetigo, and it's often a yellowy crust that you'll see.
Yeah, you could also see it, can't you, in tinea capitis,
Yes.
which unfortunately is very common in children, mainly between 4 and 7, and particularly in African children of Afro-Caribbean origin, and boys, apparently more common in boys than girls. There you go. Yeah.
Okay. We're also looking for scars, and these may be thin, and they're atrophic, and they might be thick, where there's been hyperproliferation within the wound boundary, and that's called a hypertrophic scar, or they may be very thick with extreme hyperproliferation beyond the wound boundary, and this is called a keloid scar, and this is, as you all know, is much commoner in black skin.
Yeah, and is very unsightly, unfortunately, for people. Yeah.
Go on, Fran.
Oh, sorry. Okay, so with carrying on, so you've got ulcers, and we've seen lots of ulcers come through on the website. So that's when you've lost the epidermis and the dermis, and they can often be chronically infected. They can often be quite painful, and that typically heals with scarring. We have a lot in primary care, in general practice. We have a lot of patients who have ulcers, mainly due to poor blood flow. So they get a damage in their lower leg, and just due to age and atherosclerosis, they have poor blood flow to the area, and they take ages to heal, and they come in for weeks and weeks and weeks for dressings. Yeah. a fissure, which is just a small crack in the epidermis, often due to excess dryness. And actually, I see this an awful lot in youngish women who have who come see me with chronic vaginal candida. The candida sort of irritates the skin, and then they just get these tiny fissures around their vulvas. But I mean, you can get it anywhere. So classically, again with eczema, so the skin's very dry and it just cracks open. And then striae. Yeah, and then striae, which is just a posh way of saying stretch marks. So they typically are sort of purpley pink and then go to a paler white colour, and normally they're associated with growth spurts and pregnancies. Yeah.
Moving on to the M of scam. So this is the morphology or the structure of the lesion. So this is where you're needing to lay your hands on, isn't it?
Yeah.
Well, or maybe not. No, this is still describing. Sorry. No, it isn't really laying your hands on, but I would be tempted to. I think that's the thing at this point.
I think with all these things is we talk about it in order, but actually you're doing them all at the same time. And I think so I train people to be GPs, and it's all very much like you take the history from the people and then you examine them. But actually what I do, and I noticed this yesterday because I was doing a joint surgery with my trainee, is you kind of do them all at the same time. So, you ask a few questions, and then because I only have 10 minutes, I'm moving the person to the examination couch, trying to examine them, still asking them questions, So I think with what you're saying, quite rightly so, is you'll be thinking, what's the structure of this? Go on, I'll touch at the same time. You're not going to
it gives you a few more clues as well.
Exactly. Yeah. So although we teach it in a very linear fashion, obviously you won't necessarily be doing it quite this way. So sorry.
So we'll run through these quite quickly. So a macule is a flat area of altered colour, like a freckle. A patch is a larger area on the skin which is altered colour or texture. So, for example, a large birthmark or a port wine stain. A papule, now this is a solid raised lesion, for example, that you might see around the eyes as xanthomata, which is due to high cholesterol. Nodules, now these again are raised lesions, but these are slightly bigger ones, bigger than 0.5 centimetre in diameter, and they have a deeper component to them. For example, pyogenic granuloma.
I only discovered what they were recently. Sorry to sound stupid. So I had a pregnant patient, and I don't know if anyone knows this, but apparently they're very common in pregnancy and they tend to go away on their own. So that was what I learnt about them. Just in case anyone out there is seeing pyogenic granuloma.
Yeah, very interesting.
Sorry.
Okay, keeping whizzing through. So a plaque. This is a palpable scaling raised lesion, which is usually a bit bigger than 0.5 centimetre in diameter. And an example of this, again, would be psoriasis. So we've mentioned psoriasis before with the scales. Vesicles, these are raised, clear fluid-filled lesions that are quite small.
Right. So they're small blisters, aren't they?
They
Vesicle
are.
is the way of saying a small blister. So that would be chickenpox, for example.
And a bulla is a large blister, which you
Yeah.
might see after an insect bite.
Yeah, or burns, things like that. I got burnt on the exhaust of a motorbike once, and I had a massive bulla from that. Yeah,
we're learning a lot about your past.
Sorry, I know. I'm just a disaster. What can I say? Sorry.
Okay, so moving on to other lesions like pustules. So this is a pus-containing lesion. They're usually quite small. So, for example, acne, you'd see those. Abscess is again another accumulation of pus, but it's in the dermis and it's usually a bit bigger than a pustule, and you might see this like around the nail, and it's a paronychia. And moving on to another type, a wheal or a hive. This is a transiently raised lesion due to dermal edema. So you'll see this in urticaria, or particularly in the UK at this time of year, nettle stings.
Minnie and I were talking about the dangers of running cross country and how we both got stung by nettles earlier on, weren't we?
Very vicious at this time of year. So the next one to come to is a boil or a furuncle, and this is a staphylococcal infection around or within a hair follicle. And a carbuncle is again a staph infection adjacent to hair follicles, so it's multiple boils or furuncles.
There you are. I don't think I actually knew what a furuncle was, so that's quite useful.
That is useful. They're good words. They're good words.
Yeah. So we know that that's a lot of terminology. Please have a look at the guide that I'm going to attach, because it has photos, and I think that's just a little bit more useful to look at, and for the words then to stick. But these are really useful terms for us to be using. And then just to say, so with moles, don't forget there's the A, B, C, D, which so you're looking at these features, and if any of these are present, then they increase the likelihood of that mole being a melanoma. So they are asymmetry, so that means it's not regular in a mirror image, an irregular border, 2 or more colours within the mole, and a diameter of more than 6 millimetres. So just be mindful of that.
Yeah, that's a useful acronym, actually. And then finally, we get to touch the skin. So we'll palpate the lesion. We're going to feel its surface, whether it's smooth, the consistency, is it hard or soft? Is it mobile? Can you wiggle it around? Whether it's tender, so obviously be careful while you're palpating, and feeling the temperature of it, as this may give you a clue as to whether it's an infection or not.
Brilliant. And then finally, to the last thing, so we've done inspect, describe, palpate, and then we're going to do the systematic check. So you may want to, depending on the patient and what they've got, you may want to examine other systems, respiratory, cardiovascular, but you're definitely going to look at the nails, the scalp, the hair, and in the mucous membranes as well.
Lovely. Well, thank you, Fran. So as we mentioned at the beginning, communication is key, and using these this terminology to describe and record your findings accurately will really help our dermatology volunteers to give you a more accurate and helpful advice.
Brilliant. Thank you very much, and goodbye from me.
And goodbye from me.